where the experts meet. Online learning, practical and sweet. Every Saturday, 9 a.m. Central Time. YouTube, Facebook, X, and LinkedIn. Online.
Hey, welcome to UroNurse. I'm your host, Vic Senese. Nice to have everybody here today. And be sure to like and subscribe. Keeps our show going. Today, we got a great show for you today. Dr. John Lin, those of you that have been with the show for a while probably remember that name. Dr. John Lin started when we kind of got UroNurse first off the ground and been with us for several episodes in the past. And he's coming back to do a great talk for us on the gold standard still. I think it still is on TURs of the prostate. But let's bring our group in. We also have Lori Atkinson, our co-host, joining us. And hey, welcome, everybody. How you doing today?
Good morning, everyone.
Good morning.
So,
welcome, everybody.
Nice to have you back on the show, John. It's always been a great time having you with us. And Lori,
yeah, thanks for having me back. Enjoying it.
Yeah. So, hey, just for those of you that are watching, John and I did not coordinate our wardrobe. This is just coincidental. Otherwise, we should have gave Lori the.
I didn't get the message.
Memo.
So
You didn't get the memo. Okay.
All right. Well, John, I'm going to turn it over to you, and I'm going to let you go ahead and take it.
Well, first of all, it's great to see a familiar name in the comments. Katie, thanks for joining us from the cold Illinois. 41 degrees out here in Gilbert, Arizona today, where I am in private practice. And today we're going to jump right in to talk about BPH, or benign prostatic hyperplasia, enlargement of the prostate, basically affecting over 40 million men in the US every single year. There are not enough urologists just to take care of this problem. So there are a lot of options out there, and I happen to be very passionate about TURP, which happens to be the gold standard when it comes to managing enlarged prostates. And let's begin by talking about who discovered this thing. Well, a guy named Maximilian Stern in 1926, believe it or not, 100 years ago, developed the Stern resectoscope. And he has a slightly color history when it comes to the AUA and Dr. Stern. So somehow he got kicked off, and then I don't know if he ever got back on the AUA roles. But he developed the Stern resectoscope back in 1926. That's 100 years ago. So this technology has been around for a long time. It's stood the test of time. Early limitations, I mean, it cut really well, but then it didn't stop the coagulation. It didn't stop the bleeding too well. Coagulation was not very good. Lighting was not very good. There was significant bleeding, some technical challenges. And in 1931, Dr. Davis modified the resectoscope, added a bigger viewing angle, wider loop to cut the tissue, and cutting and coagulation currents that you can control with the foot pedal, which is how we perform TURPs now, with the foot pedal, one pedal for cut and another pedal for coag. And then you have Dr. McCarthy, who combined the improved optics with the Davis-Stern concepts and added some insulation to create a new resectoscope, which became widely adopted. And in the 1940s, Dr. William Milner and others refined the technique and demonstrated in a large series that this is a safe and durable procedure, and it became the standard it is today. So what makes something the gold standard? Well, first of all, it has to be very effective in treating the patient and relieving his symptoms. Not only that, the patient has to do well after surgery and during the surgery. So low morbidity is super important. And I don't know if you know this, but 18% of GDP, or $1 in every $5 in US economy, is spent on healthcare. So for something to be the gold standard, it has to be of low cost. And lastly, when I do something, I want to do it once and not have to see the patient back for a long time, if ever. So it has to be durable. And instead of talking in theoretics and just presenting a lot of data, I'm a very practical, tactical type of guy. So when I talk about a topic, I want to just give you some examples. So let's start with maybe a case of a 65-year-old guy with severe low urinary tract symptoms, very bothersome to him, affecting his quality of life. And one of the things that I do when the patient comes in with complaints of trouble urinating is to check his uroflow to see how well he's actually voiding. So we advise him to come in with the full bladder and check his uroflow. And this is what his uroflow looks like. This is actually a uroflow from just a few days ago of a gentleman who came in with a similar complaint. You can see on the vertical axis the speed in which the urine is coming out of his urethra, and then on the horizontal axis, you can see the time it took for him to void. So the overall pattern is what we call an obstructive voiding pattern. And on the nomogram below, on the left side, the average flow rate, on the right side, the maximum flow rate are both in the dark area, meaning it's slow. Okay, what's next? Well, on follow-up, first I see the patient do a history, physical examination, get a uroflow, and on follow-up, we schedule him for a uro cuff. So uro cuff showed that his bladder has to squeeze really hard to get a good flow out. So high pressure, high flow. And interestingly, he did not empty his bladder. He had 250 cc's of post-void residual. And the next thing I schedule the patient for is cystoscopy. Now, let's talk about cystoscopy. In the Thriving Urology Practice Facebook group, something that I created many years ago with thousands of US-based urology people in it, I posted something about cystoscopies. And I said, it still shocks me that in 2026, urologists are not routinely using cystoscopy to evaluate men with BPH or low urinary tract symptoms. Cystoscopy is something that I do routinely, 20 plus times a week for a urologist, for just myself. So I evaluate men with BPH with cystoscopy routinely. Now, some of the objections when it comes to cystoscopy is that, the patient's a little scared or apprehensive about cystoscopy. So if the physician, I found out over the years, if the physician or the APP is uncomfortable in recommending a particular workup, particular medication, particular surgery, the patient will perceive that discomfort. And speaking of discomforts, for cystoscopy, a lot of guys are anxious about, is it going to hurt? And anxiety. And what this slide is saying is that you can guide the patient through that anxiety through what's called verbal anesthesia, talking to the patient about what's going to happen, what to expect during the procedure, or you can prescribe some diazepam or some anxiolytic oral medication. But I found these medications, when it comes to vasectomies, when it comes to biopsies, when it comes to cystoscopies, they don't tend to work well, and a lot more logistical issues. Somebody will have to take the patient home because you shouldn't have the patient take an anxiolytic and then have them drive home. So logistically, it's too much hassle. Whatever I want to do, I want to minimize the friction for the patient to take the desired action that I want him to take. So I found over the years, the best way to go about alleviating fear, anxiety, decreasing pain, and sometimes nitrous oxide serves as an anxiolytic. Nitrous oxide. It truly, people throw around, it's a game changer, it's a game changer. If your practice is not using nitrous oxide, definitely look into it. I have no financial relationship, but definitely look into it. So nitrous oxide will help decrease anxiety, decrease the perceived pain, and also sometimes it makes the patient forget about the actual procedure. And no driver needed. It's patient demand, meaning the gas is not flowing all the time. He just holds the mouthpiece and forms a seal around the mouthpiece, and then breathe in, breathe out. Without doing that, there's no gas being delivered. Super safe. So I digress. Okay, let's check out this guy's cystoscopy and what we see. So this is going through the prostatic urethra, going towards the bladder, and you can see the pink from both sides of the prostatic urethra. And clearly you can see the obstruction. And this is a static shot of what it looks like. You can see the lateral lobes there, and then during the cystoscopy, the video, you saw the backside also coming up, causing obstruction. So this is what you see when I perform a flexible cystoscopy in the office. Not only do I look in retrograde, after I get into the bladder, I turn the telescope 180 degrees to look back at itself, look at the actual bladder neck, look at the bladder outlet. And this is what we saw when we flipped the telescope around. So what is being shown here is that this big prostate is not just growing outwards and also inwards to cause blockage. It ran out of space, so it had to grow somewhere, and it grew into the bladder. And this is what you're seeing, this big mound, the big cheeks that are coming in to the bladder. This is growing into the bladder. And that black thing is the flexible cystourethroskop retroflexing, going back and looking at itself. So that's what we're seeing here. And let's assume that on transrectal ultrasound, this is a 60-gram prostate. And clearly you saw that there's a large amount of intravesical prostatic intrusion. And something that in pre-operative counseling or during this workup, I always ask the patient, are you done having kids? And just because he's older, typically when these guys come in for BPH, these are typically older patients. Just because he's older, I'm not going to assume that he is done having kids. So he may be a Hugh Hefner or some rock star. Never know. I want to make sure that he is no longer interested in natural fertility, because TURP tends to cause retrograde ejaculation. And also, I somewhat jokingly and not jokingly say, hey, you don't have an OnlyFans account, do you? You're not in the adult entertainment industry, because retrograde ejaculation would affect his performance. And lastly, he wants a cure and not a Band-Aid. Okay, he wants a cure. He's not just interested in making something temporarily better and then needing something done later on. So these are the things that I talk about. We have a 60-gram gland in a 65-year-old guy with severe lower urinary tract symptoms, big prostate pushing into the bladder, and he's done having children, and he is favorable. He's a favorable candidate for some sort of intervention because he wants a cure. So what are the options? Well, we have a smorgasbord of choices. It's almost as overwhelming as a cat in a room full of rocking chairs. You've got medical therapy. Well, medical therapy is not a good idea for this guy with this big prostate pushing into the bladder. Medication, I know it's not going to work. And also minimally invasive surgical treatments, UroLift, Resume, etc. With that big prostate pushing into the bladder, he's beyond minimally invasive surgical treatments. And then we have aquablation. I affectionately call it aqua TURP. So aquablation has limited, longer than 5-year data, about a 3% blood transfusion risk, and definitely requires a higher cost to get into it because you have to buy the robot. Also, the disposable costs are much higher than a traditional TURP. You need this specialized equipment to do the procedure. There's a significant UTI rate, and what's the biggest problem for me when it comes to aquablation is that you have to do the aquablation using the specialized equipment, using the higher cost disposable. Immediately during the same aquablation case, you have to open up a TURP instrument tray to do possibly more resection of any residual tissue, and definitely you will need that instrument, the TURP instrument, to stop the bleeding or coagulation, because aquablation simply shoots water jets at the prostatic adenoma and does nothing for coagulation. So you would have to bring that TURP instrument in to stop the coagulation of the tissue that you just water jetted. So that is aqua ablation. I call it aqua TURP. Okay. And so it's not just costly, it requires specialized equipment. You have to worry about, you still have to open up TURP instruments. So I'm thinking, why do I want to do an aquablation when I'm going to incur the same cost when it comes to equipment? I still have to bring out the TURP instruments. Next, you have holmium laser enucleation of the prostate. Now, there's a steep learning curve when it comes to HoLEP. You need probably over 50 cases to get really, really good at doing them. And there's an initial learning curve where it takes you a lot longer to do a whole holmium laser enucleation. There's a small risk of a bladder neck contracture, about 2%, stricture rate about 1.4%. You also need specialized high power laser to perform the holmium laser enucleation. Say you remove the prostate and then push it into the bladder, and now you need to have a morcellator to kind of grind up all that prostate to remove that prostate from the bladder. So laser, you need the fiber, you have the fiber cost, and then you need a specialized morcellator, which, believe it or not all institutions, not ORs and hospitals have that special morcellator. And then for this 65-gram prostate, yeah, you can argue for a simple prostatectomy. A lot of people think simple prostatectomy is simple. It is not simple. It means you're either making an incision on the abdomen, you're poking little holes with laparoscopic instruments or robotic assisted laparoscopic simple prostatectomy. So it is definitely a much more invasive procedure than a HoLEP or aquablation or a TURP. So you need specialized instrument, and it requires the longest op time. For instance, if you're using a robot, you have to set up the robot, dock it, and everything like that. Of all the procedures out there, this may take the longest. And it requires a very high cost robot if you use a robot. Definitely a higher learning curve, and it's definitely not suitable for small prostates. For instance, if I want to refer a patient with a 65-gram prostate to my local Mayo Clinic here in Phoenix, they would simply laugh at me and say, sorry, we don't take any prostates smaller than 80 grams. So HoLEP is a simple prostatectomy. HoLEP is reserved for a larger gland, but simple prostatectomy is not suitable for smaller glands. So if you're thinking about HoLEP or simple prostatectomy, you want to think larger gland prostate. So for this 65-year-old 60-gram prostate, not a good candidate for simple prostatectomy. Well, what's next? Well, we also have PVP, or green light laser surgery. It requires a special laser. It requires a special laser fiber, which is disposable single use. The downside of this procedure is that it has a fairly high retreatment rate at 3 years for larger glands. It's definitely less effective for prostates over 80 grams. It takes longer because it removes tissue much slower than a TURP, and higher dysuria rates. I used to do a lot of green light PVPs, but I no longer do it because patients complain about irritated voiding symptoms, and I see bladder neck contractures. Even now, I see bladder neck contractures and sometimes strictures with PVP. So it seems like there's a lot of adhesion when it comes to PVPs. As a matter of fact, I saw someone this past week, just a few days ago, who had a PVP by a local urologist who has a lot of residual tissue. I mean, he literally just had it done last year. So PVP, yes, it's an option with some of those caveats. Something that is relatively recent and it's gained popularity, prostatic artery embolization. Very high treatment rate at 21% in 2 years. Less effective in symptomatic improvement versus a TURP. It requires a skilled interventional radiologist, and not all prostatic arteries are amenable to embolization. So there's possibility of a significant amount of radiation exposure depending on how skilled the interventional radiologist is, and also possibly a lot of contrast, because how they identify these arteries is by injecting contrast, using X-ray, finding the arteries, and then finally put a catheter into those arteries and then put in stuff to block those arteries to eventually cause the prostate to shrink and atrophy. And lastly, we have the gold standard such as TURP, and we'll talk more about that in a second. And let's talk about TURP, one of the potential complaints of TURP, which is retrograde ejaculation. Retrograde ejaculation. When I tell my patients and when I counsel him, we're going to do a TURP, I tell these patients, instead of the 36% chance of not having retrograde ejaculation, I tell these patients, you almost always will have retrograde ejaculation when I perform your TURP because I'm resecting a lot of tissue, especially the apical tissue. I'm removing that tissue, which will generally cause retrograde ejaculation. However, in my frequently asked questions sheet that I give to the patient, and I tell the patient, if you're so inclined, if you're worried about retrograde ejaculation, I got you, buddy. There's something called ejaculation preserving TURP. Yes, that's correct. I can perform a TURP in a way so that I can preserve the ability for the guy to ejaculate antegrade. So there is ejaculation preserving TURP. Just because your urologist doesn't know about it, doesn't do it, doesn't mean that it does not exist. You can perform ejaculation preserving TURP. The downside of ejaculation preserving TURP is that I'm not removing as much tissue. I like to do the procedure once and not have the patient come back ever. When I do an ejaculation preserving TURP, I'm removing less tissue, so there's a greater chance of symptomatic recurrence. So I tell the patient, I can preserve your antegrade ejaculation, but most likely you may come back sooner than expected. So let's take a look at what a typical TURP looks like. And this is so if you see that silver loop that just went into the bladder, that is the loop that I use to perform the resection. When I press the pedal that is cut, it shaves away that prostate tissue. And what I'm doing right there is cutting away the median lobe, or the part that's coming up from the backside of the prostate. And I'm systematically just slowly taking it a little bit at a time. And this is a good sized prostate. I take a little cut and more seems to come up posteriorly in the median lobe. And I just systematically cut away. And I cut away that median lobe first because water or saline is running towards the bladder away from us. That is why the visualization field is so clear. And this is what happens during a TURP, resecting the median lobe. Every slice, I'm removing a little bit of tissue at a time. I'm using saline. It is a bipolar resection. It is safer. There's no TUR syndrome like in the past. So this median lobe resection is going very smoothly, very quickly. All that tissue is being removed, which at the end of the case, I will suck it out of the bladder because all that tissue is going into the bladder. At the end, I will just suck it out using a device that removes all that tissue. Unlike a PVP, we actually have tissue to analyze. And rarely, but not infrequently, this tissue will come back showing prostate cancer. So having tissue is beneficial in my experience. Now, you may be thinking, oh my gosh, that loop is huge. That prostate seems so big. Well, just to give you some perspective, images appear larger than they are in the video. But this is how big the loop is. This is the actual instrument that is used to do the resection. The loop is at the very tip right here. So you can imagine how small that semicircular loop is. It's right there. That is how small it is. So the instruments that are being used doing a TURP is actually really, really small. And what happens? What does it look like after a resection? It looks like this. This is immediately during the case at the end of the surgery, what the prostatic fossa looks like. It's a wide open channel, wide open channel. So this is immediately during surgery at the end of the resection, you've got a big open prostate. So not only is it wide open, this is, I'm soft flexing here, soft flexing. To the urologist who's actually doing the surgery, you can see that there's absolutely no arterial or venous bleeding. And to the astute urologist, he or she will see that there's absolutely no inflow going, meaning I have the fluid turned off. There's no fluid running into the bladder. The ultimate test to make sure you have perfect hemostasis, perfect hemostasis. So that is what I strive for when I do a TURP. There's absolutely no bleeding at the end of the case. And what does that look like in the recovery room for the recovery room nurse? This is a photo that I took actually just a few days ago in the PACU, post anesthesia care unit, of a TURP patient. I want my irrigation fluid to look like that at the end of the case. So what does this look like in the post-op period? The way I do this procedure is I do it as an outpatient in a surgery center. So this is done as an outpatient. There's no prolonged stay. When I do it and keep the fluid nice and clear, have perfect hemostasis at the end of the case, there's no prolonged stay in the recovery room. And I know those of you who have worked in a recovery room taking care of these TURP patients, or those of you nurses who have worked on the floor in the past, or maybe even now, depending on where you work, you're taking care of these patients post-op with the CBI, and the CBI is constantly running out, and you have to you have to empty the bag. You have to now take the bag out and drain it. It's a big pain in the butt. It's more workload for you. Well, I'm very empathetic to my nurses. I want to make your workload as low as possible. And that's part of the reason why I do it this way. Perfect hemostasis, minimal amount of time within the recovery room, minimal amount of flow with the CBI, so you don't have to constantly hang new bags and then drain the effluent, the bag all the time. That's a lot of work for you. And you're taking care of sometimes multiple patients on the floor. And now I'm asking you to spend all this time, dedicated time, taking care of this one patient. I'm not being sympathetic. So I don't want to do that. So I will put in a little bit of work in the operating room to ensure perfect hemostasis before the patient goes out to the recovery room. Now, I know some of you surgeons are saying, yeah, I know, John, I can do that. But sometimes when you get into the recovery room, you still see a little bit of bleeding. Yes, I totally get it. Yes, I do that. That happens to me as well. And it is okay. Do the best you can in the surgery. Make it look like that so that it's perfect. Take that extra few minutes to do that so that you don't have to keep the patients in the hospital and round on them the next day, or have your APP round on them. That's resources that can be used to take care of the next patient. There are over 40 million men in the US with this problem. Not enough of us just to take care of TURP or BPH patients. Okay. In addition, when I do it this way, my catheterization time is less than 24 hours, meaning I put in a 3-way catheter into the patient at the end of the case. That catheter is removed in less than 24 hours. That's one of the biggest complaints for patients when it comes to TURPs. They always ask, do I have to have a catheter? How long do I have to have the catheter? So I tell the patients beforehand, before surgery, yes, there will be a catheter, but the catheter stays inside you for less than 24 hours, And no one's ever complained when I tell them that it's less than 24 hours. And the medication that I prescribe for the patient, only 2. So almost 1 in every $5 in the US economy is spent on healthcare. I'm going to do my part to minimize that cost. And that is phenazopyridine or azo and an antibiotic of your choice. That's all I give to the patient. Now, this is great, right? What a great story. Durable, no stay in the hospital, and catheterization time in less than 24 hours. Well, just like your car, right? They'll test your car for fuel economy, and EPA will say this will give you 35 miles to the gallon. When it comes to TURPs, just like a car's fuel economy, your mileage will vary depending on the surgeon's experience and possibly his or her patients in the operating room to achieve the desired results. His or her experience dictates how efficiently the procedure is done, how long it takes for the procedure, and also the patient outcome. Believe it or not all urologists do TURPs the same way. Even though the procedure is TURP, not all urologists do it the same way with the same efficiency. Just like anything else, fixing a car, running a podcast, public speaking, doing a vasectomy, doing a TURP, the more you do, the better you get. Same thing with the whole lap, simple prostatectomy, etc. The more you do, the better you get. And not only do you have to have the experience, you have to have the mindset of what's called Kaizen. Japanese word that Toyota adopted in manufacturing vehicles. Kaizen simply means continuous process improvement. Not only do you have to do a lot of it, you have to think every case, how do I do this better the next time? How do I do this better the next time? And if you have that mindset of doing a lot of cases and also constantly thinking about how do I do this how do I do this better the next time? Shorter hospitalization, shorter catheterization time, better patient experience, no more retrograde ejaculation. These are all ways that you can, all things that you can do to improve the patient experience and also the outcome and durability of TURP procedure. So not everyone does it the same way. So let's talk about some of these variabilities. If you look at Mayo Clinic right now, under their transurethral resection of the prostate, they'll tell you that you have to stay in the hospital for 1 to 2 days. Catheterization time, 1 to 2 days, 24 to 48 hours. Let's look at a local hospital, UMass. Look it up on their website right now. Hospitalization time, 1 to 7 days. 1 to 7 days. That's like back in residency when we kept everyone in the hospital for multiple days, okay? And what did they say about catheterization time? 1 to 3 days. So your experience varies depending on the surgeon's experience. Now let's talk about the nursing perspective. What about for the nurses? In the pre-op arena, you want to look over the patient's medications, make sure he's off of anticoagulation, check the labs to make sure the EKG's there. If he's sicker, make sure the cardiac or medical clearance is there, make sure he's stopped the blood thinners, make sure the patient's been NPO, make sure there's a ride to take the patient home post-op. And then during the surgery, the circulating nurse plays a very, very important role, making sure that the patient's positioned on the table safely, there's padding, make sure there's no pressure source that's going to develop, and compression stockings to make sure there's the VTE prophylaxis. And the most important part when it comes to TURPs is the fluid going into the resectoscope during the case. That saline, if that saline stops flowing, I no longer have the ability to see. That little bit of bleeding in that small space will obscure my field of vision so that irrigant can never run out. Now, I'm also very empathetic to my circulating nurse because that irrigant, I'm not running the stopcock full open when I'm doing the resection. I open the stopcock just enough to be able to see so that irrigation does not run out constantly or frequently. That means she doesn't have to get up from her chair to hang up a new bag as often, versus if I simply have the stopcock on, open, fully flowing all the time, the fluid is going to run out sooner and she's going to have to change the bag sooner. During the COVID period, believe it or not, there was a saline shortage. I was not affected because I'm very judicious in using the saline. So I know I have a lineup of TURPs during COVID. I have a certain number of bags of saline. I know I'm going to be able to complete these resections without running out of saline because I'm very frugal. I use just the right amount of irrigation when I do the procedure, so I'm not running out irrigant. From the nursing perspective, for the circulating nurse, your main job, in my mind, is to never let that irrigant run out. So I can continue working during the resection. So not letting the irrigant run out is a huge, huge job for the circulating nurse. Lastly, in the post-op period, you're dealing with continuous bladder irrigation and giving the patient caretaker instruction, discharge instructions, and things like that. Now, let's talk about the role of the APP, the nurses, and in my case, in the office, the medical assistants. You guys play such an important role when it comes to taking care of these patients pre and post-op. My medical assistants, oh my gosh, I don't know what I would do without them. They set me up for success. I tell them all the time that you are making my life so easy. I simply do the things that only I have to do. You take care of everything else. the counseling, the questions, the phone calls afterwards. Some, believe it or not, as you know, some patients don't read the discharge instructions. They don't listen during the counseling. This is what you are going to expect. This is what's going to happen afterwards. When the catheter, you can tell them until you're blue in the face beforehand, give them the handout. They don't listen, they don't read. And so they call us. And my medical assistants take care of all of these phone calls, making my life so easy so that I can enjoy what I do. So all the counseling stuff that you take care of, just know that I personally appreciate it very, very much in offloading the cognitive load on my head as I go through taking care of patients, multiple patients, jumping from room to room every single day. What are some of the improvements which allowed us to perform TURP so safely? When Dr. Stern, Maximilian Stern, developed this back in 1926, it was not saline that was the irrigant that was being used. It was sorbitol, glycine, and consequently, that causes a lot of potential problems. The next step in advancement in TURP was the use of saline in bipolar electrocautery instead of using glycine or sorbitol, where we have to worry about something called TUR syndrome. Basically, the irrigant is going into the patient, causing the electrolyte sodium to go down, which causes all sorts of mental brain issues. That's eliminated when bipolar electrocautery came out about 20 years ago, over 20 years ago. So now most urologists, not all, most urologists perform TURPs using saline bipolar resection system. And actually, there are two major saline bipolar systems out there. The system allows the use of saline, which is much more physiologic, so we don't have to worry about hyponatremia or TUR syndrome anymore. We're no longer using glycine or sorbitol. So one of the improvements in the safety of this procedure is the use of saline bipolar resection system. Also, back in the day, the optics were not that good. And also nowadays, we are using, so back in the old days, the urologist is putting his head or her head close to the patient. Imagine the resectoscope is right in your face and you're doing the resection like that, and the patient's anatomy is right here. So any sort of fluid that spills out of the patient would cough, move, you've got a little bit of fluid coming out of the urethral meatus, well, guess where that goes, right? So back in the day, and you may see some older urologists who walk around with a hunchback at the AUA sometimes. That's because one of the reasons is because they did so many TURPs. In my mind, I think they did so many TURPs hunched over, looking over the lens. Nowadays, we attach a camera to the lens, so when I do the procedure, I'm not standing, I'm sitting down. I'm looking at a monitor right in front of me, and I'm doing the TURP in a very comfortable physiologic position. So the optics are better, lighting is better, the video camera in high definition makes the job so much easier. And for the urologists who are not using a high definition camera, I think of it this way. It's like financial independence, orgasms, and high-speed internet. Once you experience it, you will never go back. Once you start using an HD camera and in an HD monitor, you will never go back. Okay, lastly, what makes saline TURP so much safer? That's any surgery. It's better anesthesia. Anesthesia has become so safe. Some of the patients who have an unfounded fear of, oh my gosh, I'm going under. I don't like that. I'm worried about that. I tell the patients that the reason we are able to do surgery so safely nowadays is because of advances in anesthesia and intraoperative monitoring. So better anesthesia has really made things a lot safer. Now, I said a lot. If you have additional questions regarding TURP, or if your patients have additional questions regarding TURP, there's, yes, the second largest search engine in the world called YouTube. I did a live stream several years ago called TURP Frequently Asked Questions Answered, Roto-Rooter of the Prostate BPH FAQ. You can look that up online, and that should answer most, if not all, of your questions that I didn't touch on today. And lastly, if you want to continue this conversation, feel free to join the Thriving Urology Practice Facebook group. QR code is on the screen. You can also reach me at JCLINMD on all popular platforms. Thank you so much for the privilege of your time. Back to you, Vic.
Yeah, that was really great. I think you covered it all. We had a couple of questions come in, I saw. I'm going to bring those up right now. So Katie Bortelli asks, if a patient has a history of kidney stones and BPH, will TURP help?
So kidney stones are up in the kidneys, and then sometimes they get stuck in the ureter. Rarely do they dump into the bladder. TURP simply addresses the prostate. Now, if you have kidney stones that you pass frequently and you have a big prostate, theoretically, it could get stuck in the bladder, but TURPs in general are not designed to take care of kidney stones.
Yeah, it's really the treatment for bladder stones. Next question here is from Roger. With this procedure, will the patient only lose the internal sphincter?
Yes, that is absolutely correct. That's a great point. Believe it or not, my dad needed a TURP over 30 years ago. He's 94 now. He went into urinary retention, and on the way to the OR, I said, "Dad, why did you wait so long? You went into urinary retention not once, not twice, 3 times. He went into urinary retention 3 times and tried all known available medication. Why did you wait so long before you had a TURP?" And he said, "I was worried about urinary incontinence." The external sphincter is the one that controls the incontinence. That the continence control is at the external sphincter. That's under your control. So for the man, the ability to not pee on yourself, that sphincter, that valve is not damaged during TURP if the surgeon did his or her job. So incontinence rate is extremely low. You will have some urge incontinence, typically at the very beginning of your recovery period, because there's no more big prostate to help hold your urine back. That prostate is unobstructed. So now you have to depend on your external sphincter to control your urine. So that's the role of the internal and external sphincter. Internal sphincter is removed during the TURP procedure. The external sphincter is what really matters in preserving continence.
Now, how do you preserve ejaculation?
How do I preserve ejaculation? That's a great point. So ejaculation preserving TURP can be performed by preserving the apical tissue. So as you're going towards the prostate from the distal urethra, from the urethra, you go through the external sphincter, you go to the apex towards the tip of the prostate. That part of the prostate is preserved during aquablation or a TURP to preserve antegrade ejaculation. So the proximal or the base or the middle part of the prostate is what I would resect and open up, and I would preserve the apical tissue so that there's antegrade ejaculation.
So the internal sphincter is still destroyed by the procedure.
Yes. There's a misconception out there for a lot of people that the antegrade ejaculation is preserved by not disturbing the bladder neck. That is incorrect.
Okay, good. One more question just came in here from Rita E. After TURP, pathology reveals prostate cancer. Is the post-op procedure now called a channel TURP at follow-up?
I'm not sure. So channel TURP, I think Rita, I think you mean after a biopsy, pathology reveals prostate cancer. And then because the patient has trouble urinating, you do a TURP after the initial diagnosis of prostate cancer. So the patient that has prostate cancer, big prostate, also trouble urinating, and then you take the patient to the OR to do a TURP. A channel TURP is a very limited TURP. You're not creating the widest channel possible. You're just creating a small opening to allow the patient to void. I generally don't do that because I want to do something once so that he or she doesn't need to come back, because I don't know what type of treatment that prostate cancer is going to take on. So I don't do a channel TURP. But if you're saying that after TURP, the pathology shows prostate cancer, post-op procedure, Yeah, it doesn't make
TURP
sense because your
already-
TURP, so the prostate's already wide open, so you shouldn't have to go back and do a channel TURP. But a channel TURP is a limited TURP. You're
It's
not
kind of like
removing.
the tulip procedure. Where they
No,
just do the
channel TURP is
incision.
no, you're not incising the prostate, but you're actually resecting, and you're just creating a little channel in the middle,
Just
not
smaller.
resecting all the way out to the prostatic capsule.
Gotcha.
So you're just you're doing a quick procedure, creating a channel, and call it good instead of creating a big channel.
Now, Lori, have you seen a bag after a TURP as clear as what Dr. Lin
No.
just showed?
Never once.
Me neither.
Come to my PACU. Come to my PACU.
I saw that. I'm like, is there anything even in that bag? Is he like, really?
If it's not clear like that, it's very light pink.
Yeah. Now, our physicians, at least as far back as I go, were doing the monopolar with the glycine, and so the trick with that is you had to be fast because like you said, you had to worry about the water intoxication. So they didn't spend a lot of time trying to cauterize every little bleeder, and they came back, and your job was keeping that constant irrigation so they didn't block up.
I have a question for you, Dr. Lin.
Yeah.
So a lot of these patients come in on alpha blockers or prostate shrinkers. At what point do you stop them, and do you stop them completely? Do you keep them on the prostate shrinkers for future growth? What do you do with that?
Okay, so immediately after, on the day of the surgery, if they're taking both, like say an alpha blocker and a 5-alpha reductase inhibitor, typically tamsulosin and finasteride, I stop both medications that same day. I do not keep them on the medication because I create a big channel. So I eliminate 2 medications. Yeah. I tell them, hey, you know what? Not only am I going to make you pee easier, you're going to lose 2 medications. And they're so excited about that. Now, recently, I'm constantly thinking, how do I do this better? How do I do this better? I did it before, and then I stopped, and then now I'm going to try it again. Is by putting patients on 5-alpha reductase inhibitors several weeks prior to the actual TURP to see if I can
bleeding?
Yeah, for intraoperative, maybe postoperative bleeding to drive that down even lower. So I'm weighing, okay, the generic cost of finasteride for a few inconvenience of the patient taking it for a few weeks, and the potential benefit of not having postoperative clot retention. So I think it's worthwhile to do it, and also possibly less bleeding during the surgery. So the case goes faster, the patient's under anesthesia shorter. Again, lower cost to the overall healthcare system.
Right.
Great. What's your maximum size that you can do a prostate outpatient like that?
So it depends on the comfort of the urologist. I will resect all the way up to 100 grams without any problems.
Wow. That's great.
And the technology that you use matters too. I'm using the Olympus ESG 400 generator. I'm using the medium loop, so it cuts very quickly. You saw in that resection video, I'm not slowing down. I can go even faster than that. But that is very typical of just going and cutting.
I noticed that too. The coming off the loop, it was so much cleaner than what I'm used to seeing when the old days when I was assisting.
Mm-hmm.
So, yeah.
One more question.
How long?
Sorry.
Yeah, go ahead, Lori.
Regarding their PSAs post-op. So obviously they're probably going to have a new baseline, correct? And how do you monitor that?
Yeah. So the PSA, so sometimes guys will come in with elevated So PSA is highly correlated with the size of the prostate. So these guys with big prostates, they usually have trouble urinating, and they also have an elevated PSA. Say you do the workup for elevated PSA, it's normal, or the patient doesn't care about the elevated PSA. He just says, I want you to take care of my TURP, take care of my prostate with the TURP. And I tell these patients, I'm going to make you feel better with voiding. You're going to get off of both tamsulosin and finasteride. Your PSA is going to drop down to normal, and I'm going to have prostate tissue to analyze. So multiple benefits to a TURP. After TURP, I expect the PSA to be in the normal range. So you have to recheck the PSA.
And how long's your average case, start to finish?
We typically book them for an hour.
Wow.
Yeah.
It's come a long way.
Yeah. Again, it is definitely surgeon dependent. You have to have the experience. You have to have the
Absolutely.
mindset of wanting to do this better every single time.
Yeah. And, I think that even what I've noticed is the younger guys coming out, they're not as experienced doing TURPs because they're going to mostly these minimally invasive procedures now. That's where their kind of comfort level is. So finding somebody who's been out there for a while and knows how to do the old fashioned TURP is something that, as you say, we got a shortage of urologists as it is. So it's going to be even more short.
Yeah. It's cost effective. It is durable. It's a classic. It has withstood that's the test of time.
Yeah.
Instead of the newer technologies that are out. I mean, that's great. The newer technology is minimally invasive. There's a lot of population that needs to be addressed, and not everyone needs to have a TURP. But when it comes down to it, TURP is durable, it is cost effective, and very effective.
Yeah. And I think it does get some patients into treatment sooner than they would have otherwise. The threat of going to through surgery, even if it's an outpatient, is still more than, I don't know, office procedure has got to be nothing, right?
Yeah. We do resumes, urolifts in the office, I-10s in the office now. So that's so doing nothing, observation, medical therapy, then you have minimally invasive surgical treatments, and then you have more invasive stuff like TURP or HoLEP or aquablation.
Yeah, it's great. Rita Yi has a good question here. What's future innovations for BPH treatment is forthcoming in the next 10 years, if any? Are you seeing anything in the future?
There's so many, because this is a huge addressable market for
Isn't that crazy?
Yeah, it's when it comes to startup companies that are trying to innovate and try to be profitable, they will look at the total addressable market, how much business there is in a particular space. When it comes to BPH, it's such a big addressable market that there's so many new technologies that are coming out that you have not heard of. I love this field, so especially BPH. So I have my my ears to the ground just to figure out what new is coming down pike. Just look for it. There are a lot of newer, minimally invasive procedures that are tailored to be done with less trauma and hopefully some durability and efficiency. Look for it for sure.
Well, it's great. Any other questions for you, Lori?
No, I think that was great. Thank you, Dr. Lin. Appreciate you
Alrighty.
being back.
So I got a
Great
little
to be
promo
back.
for
Great to
next-
see everybody. Thank you for the questions.
Been a ball. We had we had a large live audience here watching too, so it's great. You pulled back some of your old fans, I'm sure. Next week,
How can the latest AI tools dramatically improve your productivity, creativity, and workflow without replacing the human touch? In this episode, Vic Senese breaks down how today's most powerful AI tools can help professionals, creators, educators, and clinicians work smarter, faster, and more creatively. Artificial intelligence is no longer just a tech buzzword. It's a practical, everyday tool that can help you generate content, organize ideas, streamline workflows, automate repetitive tasks across nearly every field. This episode shows you how to leverage artificial intelligence responsibly and effectively. Join us on February 28th at 9 a.m. Central Time to learn more.
all right. I have a ball using all these new tools with AI, so I thought this would be a good time to kind of share some of it. You're seeing it every week when you see these promos that are all created through AI. That wasn't me sitting in front of those computers. That's all AI generated. So, hey, I got a shout out. I got to put this in here for the defender of the detrucer himself, Dr. Wayne Kwang.
Yes.
Give you a bravo. So thanks for watching. Yeah, this is a great episode. I really am glad that you're able to join us and kind of get your spin and your expertise on it, because, the thing is, as you said, there's a lot of men out there with BPH, and we know if you take too much time, and Lori and I can, and I'm sure yourself can all attend to it, you come in and that patient walks in the office and they're in retention and their bladder's shot. You're not going to get them out of retention no matter what you do. You want to intervene sooner than later. So men, make sure you get checked out by a urologist and stay on top of it. You only got one bladder. And as somebody once told me, you can't replace it. There's no bladder transplantation surgeries. So, all right.
Not yet.
Great.
Not yet.
Yeah,
Not yet. Yeah, that's keep your eyes open for that one. All righty. Well, we'll see everybody next week for a little talk on AI given by me. I haven't done a talk to the group for a while, so thanks again for joining us, Dr. Lin and Lori. Always a pleasure to have you on the show.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.